hypertensive crisis, this is what we will be discussing in this video. Blood pressure elevated greater than 140 by 90 mm of mercury refers to hypertension. Hypertension is amongst the commonest non-communicable diseases worldwide and is a silent killer. Hypertensive crisis includes hypertensive urgency and hypertensive emergency. So it is important to differentiate hypertensive urgency from hypertensive emergency. So here is how we compare hypertensive urgency with hypertensive emergency. In hypertensive urgency, the blood pressure levels exceed 180 by 120 mm of mercury. There is progressive end organ damage and the signs and symptoms are headache, dizziness, fainting, nausea, chest palpitation, chest tightness, dyspnea or shortness of breath, and increased restlessness, agitation and anxiety. In hypertensive emergencies, the blood pressure levels are extremely high, greater than 220 by 140 mm of mercury. There is damage to the vital organs and this can result in serious complications. The signs and symptoms are related to target organ damage. The symptoms that pertain to brain includes transient ischemic attack, hypertensive encephalopathy, stroke. The retina of the eye may be affected and this can result in acute retinal hemorrhages, hypertensive retinopathy and acute papilledema. The heart may be affected and this can manifest as acute left ventricular failure, pulmonary edema and acute coronary syndrome. The kidney may be affected and this can result in acute hematuria, rise in serum creatinine level, proteinuria. So it is important to look for evidence of target organ damage in addition to categorizing the subject on the basis of blood pressure records. Therefore, tests such as serum creatinine, electrolytes, fasting glucose and lipids, chest X-ray, ECG, echocardiography and urine analysis may be ordered. Referral to an ophthalmologist for retina checkup may be warranted. When it comes to blood pressure lowering in hypertensive urgency, the blood pressure which is greater than 180 by 120 mm of mercury is reduced to 160 by 100 over a period of 1 hour, and then from 160 to 100 it is normalized gradually over the period of 12 to 48 hours. In hypertensive emergency, the blood pressure levels are extremely high, that is greater than 220 by 140 mm of mercury, and the goal should be to reduce the blood pressure by not more than 25% of the presentation baseline in the first 2 hours. In the next 4 hours, it can be reduced to 160 by 100 mm of mercury, and then from 160 to 100 to normal blood pressure over a period of 12 to 48 hours. In this way, blood pressure should be gradually lowered and should not be reduced too rapidly or too excessively. Rapid reduction in blood pressure may lead to cerebral hypoperfusion and damage to end organ, and this can cause worsening of the clinical condition. There are two situations in which the blood pressure may need to be reduced more rapidly, and these are acute myocardial infarction and acute aortic dissection. So these are the two exceptional situations where rapid reduction in blood pressure is required. Next, we move on to the medical management of hypertensive urgency and hypertensive emergency. In hypertensive urgency, rapid, short-acting oral medications are preferred and the drugs are captopril, nifedipine, amlodipine, labetalol, prazosin, clonidine are preferred drugs. In hypertensive emergencies, rapid-acting parenteral agents are preferred and these drugs are sodium nitroprusside, nitroglycerin, labetalol, esmolol, nicardipine and hydralazine. So now let's discuss the drugs that are used in hypertensive emergencies. Sodium nitroprusside is the drug of choice in hypertensive emergencies. There are a number of reasons why sodium nitroprusside is selected. Given intravenously, it has an immediate onset of action, rapidly reduces blood pressure, it is easily titrable and its action is easily terminated on discontinuation. However, the patient must be monitored closely for hypotensive episodes and tachycardia. Sodium nitroprusside is metabolized in the red blood cells or erythrocytes to liberate cyanide and and cyanide ants gets accumulated in presence of liver disease and in patients receiving higher doses and prolonged infusions of sodium nitroprusside. In patients with poor renal function, thyrocyanate, a toxic metabolite of nitroprusside, gets accumulated, and this can cause symptoms of paresthesia, seizures, numbness. Therefore, in patients with liver disease or kidney disease, sodium nitroprusside is contraindicated, and in these patients, IV nitroglycerine can be used. And if you remember, nitroglycerine has a favorable effect on coronary blood flow and pulmonary gas exchange. Therefore, it is suitable in the setting of acute coronary ischemia and after coronary artery bypass graft surgery. But it should be kept in mind that nitroglycerine is contraindicated in patients with inferior myocardial ischemia associated with right ventricular infarction. As we know that nitroglycerin predominantly acts by reducing the preload, so by causing drastic reduction in preload, it can adversely affect the cardiac output and can worsen the clinical condition. Therefore, IV nitroglycerin is contraindicated in a patient with right ventricular infarction and inferior wall myocardial infarction. The next drug is labetalol. It is an alpha and beta receptor antagonist and is an alternative in hypertensive crisis. Labetalol is the drug of choice in hypertensive emergencies during pregnancy and is particularly useful during adrenergic crisis, for example, clonidine withdrawal or pheochromocytoma or after coronary artery bypass graft surgery. The next drug is esmolol. Esmolol is a cardioselective beta blocker and has a short duration of action. It is useful to control and maintain blood pressure during surgical procedures. It is also useful in presence of supraventricular arrhythmias and in acute aortic dissection. The next drug is phenoldopam. Phenoldopam, unlike dopamine, is a selective agonist on peripheral D1 receptors and has no effect on beta-1 receptors of the heart, and therefore there is no tachycardia associated with phenoldopam. It is very useful for controlling severe episodes of hypertension. By stimulating the D1 receptors, it causes vasodilatation of the arterial beds, including the renal, coronary and the mesenteric arterial beds, and this increases the renal blood flow, causes natriuresis, increases the glomerular filtration rate, and therefore this is the drug of choice for the treatment of hypertensive episodes associated with concomitant renal insufficiency. So the next drug is nicardipine. Nicardipine is as effective as sodium nitroprusside in the management of severe hypertension and post-operative hypertension. Lastly, IV hydralazine can also be used in hypertensive emergencies. However, it is seldom used now because of its lower efficacy and it offers no advantage over other antihypertensive agents. However, it can be used in pregnancy-related hypertensive emergencies. So in this way, these drugs are used in the management of hypertensive urgency and hypertensive emergency. So in this session, we have learned how to differentiate hypertensive urgency from hypertensive emergency, the blood pressure lowering measures, the precautions, the usage of antihypertensive agents in the management of severe episodes of hypertension. Thank you so much for watching. Please like and subscribe to this channel.